Good morning, everyone. Good morning. Thank you. There's been a particular focus on endometriosis, this ISUOG, but I think there's been a failure, really, in terms of discussing other causes of pelvic pain. Other causes of pelvic pain, they can mimic the symptoms of endometriosis. In a significant number of patients, there's coexisting conditions, gynecological conditions. There are underlying conditions that drive the endometriosis. So really, we can't talk about endometriosis without covering the issue of pelvic pain generally. And we just talk about gynecological causes. We're not talking about the bladder, the bowel, primary bowel disease, etc., etc. Modern ultrasound offers us an amazing range of technologies now in terms of assessing gynecological disease and associated functional disorders. Whether it's the actual imaging modalities that we have available to us, or whether it's our actual scanning technique. Remember, gynecological disease is not confined to the pelvis, so there's still a very important role for transabdominal scanning. And really, if we're not competent at renal scanning, liver scanning, abdominal aorta, bowel, etc., we're not competent at gynae scanning. We have to adopt this flexible approach and be competent. And certainly from an endometriosis point of view, there's certainly a considerable role for transrectal scanning. And just to emphasize how important transvaginal scanning is, apart from the increased quality of our 2D grayscale imaging, the sensitivity of our color Doppler, our SMI, and also it gives us access to high-resolution 3D, advanced 3D technology, as well as promoting the role of contrast sonography, particularly saline infusion sonography, as we'll see in this particular talk. Just a few examples of really how we have to use this flexible approach to scanning pelvic pain. This is a case of adenomyosis. I think that's pretty obvious if we look at the grayscale texture. We need good grayscale texture. If we look at the hyperemic changes within the myometrium, which we would associate with adenomyosis, and we need good 3D to look at the extent of the adenomyosis, the significance of the adenomyosis. And remember, we're not just dealing with pelvic pain here. We're dealing with infertility. We're dealing with recurrent miscarriage. But certainly the 3D gives us a far better idea of what's happening in the uterus relative to those changes. If we take this case, well, there's an obvious ovary full of endometriosis, but it's the 3D that gives us a real kind of insight into ovarian morphology and the extent of the disease. And remember, the bottom line is we're trying to give accurate information to the consultant responsible for the management of that patient, and that consultant has to decide on the appropriate line of management for that particular condition. So we've seen the importance of 3D in that case. If we look at this case, it's here's the left ovary, which we can see very, very nicely, but the right ovary is stuck up here. It's stuck up here. So we need to adopt a transabdominal approach here. Here's the right ovary there. Oops. Right ovary, and there's a chronic inflammatory mass associated with the right adnexa. This is a 16-year-old girl presenting with severe abdominal pain. We can't do a transrectal scan on her. She's an Orthodox Jewish girl. And transabdominal didn't give us the information, and with her mother's permission, we did a transrectal scan. And that clearly outlines the lesion. And obviously, with a transrectal scan, we're getting quite close to the ovary. Therefore, the colour Doppler SMI becomes very sensitive, and we can be absolutely confident that that's a benign lesion. If we look at this case, there's an obvious marine IUS there. And here's one ovary, here's the other ovary, clearly seen. But if we look at the right adnexa, we can see that lesion there. And with the colour Doppler, and certainly if we introduce 3D, we know that that's likely to be an ectopic pregnancy. And certainly the degree of vascularity we see around an ectopic pregnancy, certainly in the case of tubal miscarriage, that will reflect beta HCG levels. And finally in this group, here's a lady presenting with right iliac fossa pain. The uterus, the ovaries are okay, but there's a reactive inguinal node using transabdominal scanning. In fact, we're probably using the breast probe there, transabdominal scanning, and that was secondary to a bowel cancer. So just a few examples, just showing you why we have to adopt this flexible approach if we're going to maximize the clinical information that we can pass on to the referring clinician. The talk did actually kind of emanate from a study that we're continuing to look at. You can see here, this is approximately several thousand patients. We didn't have feedback on everything, but I suppose in very crude terms, we can divide our causes of pelvic pain into those three sections. This you might not have come across, and I'll talk to you a little bit more in detail about that. You wouldn't be expecting to talk about irritable bowel syndrome in the gynecological lecture, but you'll see it's a very, very important element to our work. If we revise that pie chart and we look at this, you can actually see that if we're going to talk in terms of functional disorders, then you can see there's a tremendous overlap, not just in terms of the number of patients suffering from functional disorders, but coexisting conditions with endometriosis and other causes, etiologies of pelvic pain. I'll talk a little bit more about functional disorders, but at this point in time, I would emphasize that the major cause of pelvic pain and abnormal uterine bleeding, it's functional. It's functional. So we'll go on to endometriosis itself, and you've seen these pictures lots of time. And we're aware that we can delineate endometriotic cysts, but there are different issues that we have to address in terms of identifying endometriotic cysts and being sure that endometriotic cysts, as we'll talk about later, are really the ongoing challenge of, in terms of ultrasound endometriosis, is to kind of look for evidence of endometriosis in the absence of endometriotic cysts. And again, we'll talk about that shortly. So here are our typical pictures of an endometrioma. The significance, though, is it's not just a matter of identifying the lesion, but we need to look at the extent of the lesion. Is there functional ovarian tissue left, or has the endometriosis totally destroyed the ovary? This is obviously the determining factor in terms of whether we aspirate the cyst, strip out the lining of the cyst and sew up a normal ovary, or whether the ovaries are removed. And you can see there the importance of 3D in terms of answering that question and identifying functional tissue within the ovary. But as I said, we need to find ways of making sure that we are dealing with endometriotic cysts. And the thing with gynecological disease, particularly involving the ovary, is that one pathology can mimic another, which can mimic another. So if we look at kind of the typical appearances of an endometrioma, in ultrasound terms, they do tend to be relatively avascular. Not in all cases, but in the vast majority, they are avascular. The second factor, which people aren't aware of, is that follow-up scans are very important. Follow-up scans are crucial, certainly in our unit, in terms of accurately defining the type of ovarian lesion. And certainly the most common issue in terms of differential diagnosis is differentiating between an endometrioma and a hemorrhagic corpus luteum. And really, color Doppler is very, very useful here. Very useful, particularly the SMI that you can see there, the color, the monochrome, in terms of looking at peripheral angiogenesis around the lesion. But also, if we look at an endometriotic cyst around a period, there are changes within the cyst. Remember, endometriotic tissue, ectopic endometriotic tissue, wherever it might be, will undergo the same physiological changes as the endometrium during menstruation. We'll see this again in terms of looking for adenomyosis. But you can see here the changes in an endometriotic cyst. As we come up to a period, we expect to see bleeding into the cyst around the period, and those changes resolve as we go into the early mid-follicular phase. So if we're unsure of what the lesion is it a hemorrhagic corpus luteum? Is it an endometriotic cyst? Color Doppler is very, very useful, and certainly follow-up examination is extremely valuable. Now, endometriotic cysts tend to be asymptomatic, but there are certain conditions where they are the cause of pelvic pain. Certainly, if you get a rupture of an endometriotic cyst and you get this horrible blood flowing into the pelvic cavity, that will irritate the tissues and that will cause pain. So certainly where there's rupture of an endometriotic cyst, then we would associate that with discomfort. Also, we can get torsion of an endometriotic cyst. If we have the right ovary, left ovary, if we look at the left ovary in 3D, you'll see this defect here, clover leaf appeared. That's because the endometriotic cyst has twisted. This is a 3D diagnosis. So again, it shows you the advantages of using 3D as well as high quality 2D grayscale. Just further images from that point of view. Endometriotic nodules tend to be more painful if they're outside of the ovary, if they're within the pelvis. And certainly here you can see a nodule and different patient, but a similar feature there. So when we get endometriotic nodules within the pelvis, then they tend to be a cause of pain, whereas endometriotic cysts tend to be relatively asymptomatic. Obviously, we associate endometriosis with adhesions. And certainly where we have ovarian lesions, and there are, you can see the flimsy adhesions there that we're opening up, then that's a sign of endometriosis and formation of adhesions. Sorry, there should have been a cine loop in here, but you've heard lots about sliding examination. It's pretty limited, actually, in the practical world. Okay, we can see that ovary stuck there. We can see if we had the cine loop there, that was stuck there. But if we take this case here, there is no way you could have performed a sliding examination on that patient. She would have hit the ceiling. But this case illustrates the value of 3D. What we're looking at here is the rectal-vaginal septum. And as we look through our tomographic cuts, as we come to that area there, you can see rectal-vaginal adhesions. And again, this is a 3D diagnosis. Obviously, in some cases, it is useful to do these kind of sliding examinations. But if you're dealing with patients with grade 4 endometriosis, then it's not always possible to carry out that examination effectively. Obviously, we can have endometriotic lesions associated with bowel. Again, to kind of emphasize our need to do transvaginal scanning, transrectal scanning, and certainly trans-abdominal scanning. So we move on to adenomyosis, and it's a strange situation. It's a situation that's kind of difficult to actually prove histologically. But I think we are fairly agreed in terms of the ultrasound features that we look for in terms of the suspicion of adenomyosis. And certainly that list would kind of tie in with what was preached last year at ISUOG. There are obvious changes that occur. As we have our differential thickening of the wall. We know we have poor delineation between our endometrium and myometrium. We have poor endometrial responses in severe cases. We actually like the role of real-time elastography, and this is kind of the manual compression. And we certainly had, we feel, a degree of success in terms of differentiating between adenomyosis and diffuse fibroid disease by looking at or using this imaging modality. I'm not quite sure why, but the shear wave technology hasn't given us the same degree of confidence as the manual compression. But again, as you can imagine, if you have someone with grade 4 endometriosis, extensive adenomyosis, the last thing they want is someone prodding the uterus. But as I said, certainly if there's extensive adenomyosis, our high-quality grayscale, our high-quality color Doppler gives us characteristic features that we associate with the disease. Now, an interesting, well, it's logical when you think about it. An interesting feature of adenomyosis is that if you have good grayscale and you look at the myometrium, obviously you can see the changes there. But if we compare those changes halfway through the cycle, they aren't there. So if we're unsure, we were doing more and more work in this situation. Very important to have the same settings, the same machine. But if you're trying to differentiate between diffuse fibroid disease, inflammatory changes, or adenomyosis, if you look at the glandular changes, the myometrial changes around a period, you would expect changes. If you look at the nature of endometriosis, you would expect changes. And you expect the myometrium to look different at that stage of the cycle compared with the ovulatory phase of the cycle. But we need good quality grayscale to give us that kind of confidence. And it's an area that we're working on at the moment, but it does help us in terms of confirming the likelihood of the presence of adenomyosis. There are other uterine causes of pelvic pain. Certainly if we have intracavital pathology, and certainly fly-through has become tremendously important to us, not just in terms of imaging intracavital pathology, but passing that information on to the surgeon, and particularly in terms of pre-surgical assessment, fly-through is of tremendous importance. In this case, we have a fibroid polyp. Here, we're looking at obvious adhesions here. These will cause pain. These will cause pain around menstruation. It's not endometriosis. And with adhesions, we do try and break up the adhesions. And we have had a degree of success in terms of doing this. And we get the impression that if we can do this, it does alleviate the discomfort the patient will have to a certain extent. Intercapital adhesions, again, the saline infusion, this is something we've been doing for about 30, 35 years, and it took a long while to catch on, but it's a very, very useful technique for all sorts of reasons. So if we carry on with pain emanating from the uterus, here are two cases. Well, this is the first case where there is a lower cervical stricture. There we can see an obvious hematometria. This is, you can't see the fundus, but this is actually a bicornuate uterus. Again, this isn't an SIS. There's actually a lower constriction here, anatomical feature, but it causes pain. Inflammatory changes, infection, will cause pain. Now, again, this is a case of infection. This is a further case of infection, and you can see the hyperemic changes there within the myometrium. But remember that you can get these changes for other reasons. You know, if you take someone with estrogen dominance, then you will get the same changes, and those patients will suffer similar clinical symptoms to patients with infection, or indeed patients with adenomyosis. So again, the colored Doppler is very, very useful to us in terms of looking at myometrial vascularity. And if we take this case here, again, it's pelvic infection. We have the complication of a coil there. We're not quite sure what that marina coil is doing. It seems to be twisted and heading towards the right interstitial tube. And just in the corner there, we have a pia salpinx. And the ovary is here, the pia salpinx is there on our shadow glass image. So they are causes of pelvic pain emanating from the uterus. If we now go to the ovary, obviously, again, a major cause of pelvic pain, and you know, nowadays we can really look at ovarian morphology very, very closely, certainly using high-quality 2D color Doppler and our 3D rendered image. The most common lesion that we're going to come across in terms of pelvic pain, abnormal uterine bleeding, is this chappy here, the active functional cyst. These lesions can cause all sorts of problems, as you'll see in a second. But from their grayscale appearances, they can look quite sinister. So this is why, as you'll see in a second, why it's important to do follow-up scans. It gives us so much more information. And certainly when they collapse down, they will cause discomfort, and you'll see why they cause discomfort in a second. So, as I said, they can look quite sinister. You know, this isn't an ovarian malignancy. We never thought it was an ovarian malignancy. it has all the features of a hemorrhagic corpus luteum. And when we do a follow-up scan, same ovary, we see it's collapsed down. The value of follow-up scans. Just leave functional cysts for a while. Obviously, we've already touched on the issue of torsion. Here's a dermoid cyst that have torsion. There's no blood flow around there. We find this lesion sitting in the pelvis causing pain. This is a secondary lesion, but you can see straight away from the color Doppler that this is a high-risk lesion. It's a source of pelvic pain. So again, here's what looks like a corpus luteum, except that's the ovary there. And it's surprising how often we see patients who have tubal miscarriage, and the miscarriage occurred months beforehand. They present with irregular bleeding, sometimes they present with pelvic pain. And again, just to show how the blood flow around that tubal lesion reflects beta-HCG levels. And that's the lesion here. This is looking at the lesion from the outside, and you can see the vessels. You can see how highly vascular the lesion is. This is looking at the lesion from the inside. Again, you can see the vessels there. You can see the peritubal vascularity there. So we have to kind of think widely. We have to think out of the box, if you like, when we're dealing with pelvic pain. So we'll go back to our ovary, our functional cyst. Now, that's the problem you have with functional cysts. See the blood there, and you can see the reaction from the bowel. This patient will present with irritable bowel syndrome. She hasn't got irritable bowel syndrome. What she's got is bowel that is irritated by the changes within the ovary. And this is a significant cause of pelvic pain. It's not pathological, it's functional. And again, if we certainly, if we're looking at estrogen dominance, then we get symptoms, significant symptoms, features within the uterus. We can see a very thickened lining there. We can see the myometrial vascularity. So if we get fluid in the pelvis, we expect that patient to have pain. And it could be acute, it can be chronic. It does vary tremendously in terms of the way it presents, the symptoms. So if you look at that combination there, that combination applies to patients with functional issues. And whether we're dealing with abnormal uterine bleeding, even postmenopausal bleeding, whether we're dealing with pelvic pain, this is the major group, the largest group of patients. It's not endometriosis, it's not ovarian torsion, it's not uterine factors, it's functional. So we have to kind of think in terms of how often this syndrome is picked up, and it isn't. So therefore we have to question our management of pelvic pain. So again, you're going to go home tonight, you're going to dream of functional cysts. And you're going to be different people when you start scanning pelvic pain. Now, if we look again at the fluid, we look again at the uterine changes, then these are the causes of the functional causes of pain. So I just flick through these because we're starting to run over time. A similar picture there, and that's what we're dealing with. This is why we bring in irritable bowel syndrome into a gynae lecture. Just one more case that I would just show you before we finish is that we're also very dismissive of retrograde menstruation, and we see this very, very often. And if we look at this case here, there's well, that's a partially shed endometrium. You see bucketfuls of fluid there, very high vascular functional ovarian stroma. That's in November, and a few weeks later, everything is gone. And this is retrograde menstruation. Our impressions is that with any period there is a certain degree of retrograde menstruation, but obviously there's a variation in the extent. And certainly in the extreme, you have patients with abnormal cycles, obviously, because they're not having vaginal bleeding, but they have repeated pelvic pain. So there's a very, very brief introduction to our thoughts, our impressions in terms of using high-quality ultrasound imaging, whether it's 2D grayscale, color Doppler, whether it's 3D, whether it's different scanning techniques, the value of follow-up scanning. And really, you know, our challenge is to kind of be more precise in our diagnosis and give the referring consultant more reliable information to work on in terms of clinical management. Thank you.